As far as manual therapy, we can do scapular neuromuscular control drills using PNF and rhythmic stabilization. So here we go. They're lying on their side, and the therapist is giving him resistance to the scapula into like protraction and retraction, both here at the elbow and here at the scapula. So here's another picture of that. Okay, good. See how the patient's protracting and retracting, and the therapist is giving him resistance both ways with this hand and then with this hand, making sure that he doesn't go up into elevation. Well, now he's doing elevation and depression. Okay, but when you're doing protraction and retraction, you make sure that they're not going into uh, any hiking. Okay, so that's a good way to do protraction and retraction, giving resistance yourself as the therapist. And here we're doing that same thing, that kind of rhythmic stabilization. The therapist, you can see the therapist is giving resistance at all different points. Okay, here, top of the shoulder, that way, and he's kind of telling the patient, we're cueing the patient, hold it here, don't let me move you, don't let me move you, and the patient doesn't know where the resistance is coming from. Okay, and these are slow, controlled movements rather than jerky movements. Okay, on the physio ball, here you can see he's using a physio ball on the wall. The therapist is directing him to kind of go up and down. You move your arm up and down, side to side, circles each way. They're not big circles, they're pretty small either way. And this is for endurance, okay? Mainly, you're not going to develop uh, big old scapula muscles, okay? You want to work to stabilize that scapula. Those scapula muscles need to work for a long time, okay? Also off the edge of the table, on the physio ball, you can do it here like that, okay? Um, to make it harder, how would you make it harder? You can move further off the table, okay? To make it easier, think about how you can make it easier if somebody can't do this. What would you do? All right. All right, let's look at this. This is another video of a patient. This is a tough exercise. Okay, he's got the ball on the table and he's doing push-ups. Look at that. So now looks like he's beating him up, but he's giving him resistance everywhere, and the patient's stabilizing himself more. So now he's doing it while he's doing push-ups. Really nice exercise. It's all about challenging the patient. It's all about varying the types of exercise, okay? It's all about trying to simulate the types of activity that the patient's going to experience when they go back to their sport or when they go back to their job or just when they go back to their life. And here's another exercise. Where's my cursor? There it is. Okay, so here's another exercise, throwing the ball against the wall. Here we go. Boom. Okay, at 90-90. Oh, and he's giving him some rhythmic stabilization at 90-90. And then he goes back to throwing it against the wall. All different ways. Good. Okay, so it's not rocket science, okay? But there are things you need to recognize, as far as when people are ready for each exercise. But it's mainly you're putting them in as aggressive position as that you think they can tolerate, and having them work there, having them do stabilization at that point. All right. Here's this guy again. Same guy as before. We looked at this one. Also for the scapula, right? Giving him all up and down the arm. He's getting resistance all up and down the arm. It's not so funny, is it? It's hard. I think he's laughing that it's hard. Uh, there we go. All up and down. Nice. And this guy with his shirt off is going to do some heavy exercise. Look at that. That is tough. Now, a lot of your patients aren't going to be able to do this, but you know what? Even just doing this on one ball, having one hand, the unaffected side on the floor, the other one on a ball, or on something unstable. This is a really tough exercise. 2 hands on the ball. Okay, it takes a lot of strength to do this, a lot of shoulder stabilization. Okay, but it doesn't have to be on a ball. Anything that's unstable that you can put your hand in. Yeah, see, this is a little bit better. So now he's on a rocker board. So it's going side to side. You can turn the board so it goes forwards and backwards, so it's unstable forwards and backwards. You can put his hands on diagonally and have him do that. You can use the fitter. I don't know if you guys know what the fitter is. We have one in at school. I'll show you, and you can have them move against resistance bands back and forth or up and down or in the diagonal. Okay. All these are good shoulder exercise. And here's your PNF. You guys learned PNF in clinical skills. So you're doing PNF. Here you go, PNF D1, D2. You can give them, you're having them bring it out and externally rotate. You can give them resistance at different points. Further, you can start proximal and work distal. Again, you can have them, sometimes I'll have them, I'll give them resistance all the way through the motion. Sometimes I'll have them close their eyes and I'll stop them. I'll give them resistance at a certain point in the motion, or I'll go back and forth giving them resistance. They bring it up, then bring it down, and giving them resistance at different points. Here you see there's Dr. Zager. She's got a different hairdo than she does now. I don't know when this was. But anyway, so she's doing a little PNF for the scapula. Same kind of thing. She's got her hands on the medial border, inferior border, this one up high. And she's asking the patient to push in, push out, elevate, depress, protract, retract. Again, in quadruped, rhythmic stabilization, we talked about that before, putting them on their hands and knees, giving them resistance, even just putting them on an unstable. Even I would say this mat is pretty unstable. It's probably pretty soft if it's a little thicker, and just having them balance here. You can even have them at first, you have them do 2 arms, you progress to 1 arm. You can have them start moving this arm while they're balancing on this arm. You can put a weight in this arm. You can have them start moving their legs. There's a whole range of possibilities that you can do for them in this position. Okay, so let's talk about exercises. What are we really training this for? Our 3 times 10, 3 times 10, 3 sets of 10. No, we need to ask ourselves, what are we training this muscle for? What's the purpose? And we're usually doing stabilization and endurance for all our glenohumeral muscles, our rotator cuff muscles, and for our scapulohumeral stabilizers. So here, we want to look at maybe doing 2 to 4 sets, but with a lot of repetitions, all right? Because we're working endurance and maybe not as much weight, okay? We can do lots of repetitions, or we can train for time as well. Most of what we do in PT is training for endurance, all right? As far as our primary movers, our strengtheners, those are our 2 to 3 sets, 8 to 12 reps at 60 to 80% of the 1 RM. Single set exercises at low intensities are most common in the very early phases of a resistance program or a maintenance program. Multiple set exercises are used to progress the program and have been shown to be superior to single set training for advanced training. Okay, so how do we put all this together? Okay, let's look at this. So we have somebody who's doing who had an arthroscopic rotator cuff repair in phase 1. We want to be a little careful, okay? Scapula clocks, you see here, scapula clocks and scapular tractions might be a little iffy due to we have too much supraspinatus activity on EMG, so we might want to hold those. But we can just do scapular depression, where's my cursor, to neutral and back, okay? So we protract and then we come back to neutral. We can do pendulums, but we need to watch out. If we keep them doing small circles and they're okay, and we think it's okay according to the physician's protocol, those small circles generate very low contraction. So those are okay for the supraspinatus and infraspinatus. But we want to use basically here to do grade 1 and 2 joint mobilizations to reduce pain and guarding, maybe with the arm elbow flex, so we don't put as much traction on the arm. PT assisted passive range of motion. If we use pulleys, I think we said this before, there's more muscle activation, so we really want to be aware. They'll use their rotation. They'll use their sling to keep them from rotating too much. We want to make sure their C-spine has proper range of motion. As far as progression, typically 4 to 8 weeks. We want to make sure that they have 125 degrees of flexion, 75 degrees of internal and external, and 90 degrees of glenohumeral, and that they have minimal substitution patterns and minimal pain. This might be hard to tell because they're not doing anything actively, but we want to make sure that they're not, they tend not to hold their upper trap, they don't elevate, they don't keep their scapula elevated, their scapula is not protracted, those types of things, okay? So we go into phase 2, which is the remodeling phase, okay? And we want to start to provide low-level forces. So the collagen fibers are oriented. We start to increase tensile strength of the repair. They can start active assistive range of motion. They can use the cane. We've all seen people do that. They hold on to the cane, so they use the unaffected side to help the affected side up, or they can use the uninvolved side just with their arms clasped. We want to make sure their scapulothoracic joint musculature is firing correctly, so they can do prone scapular retraction, depression, supine punches at 90 degrees. When they're able to bring their arm to 120 degrees, they can go there. Bench pressing, okay, no weights, but just pushing up. So they're starting to go into elevation, okay? Side-lying external rotation, okay, because that promotes high infraspinatus and teres minor activity. Elevation in the scapula plane with the flexed elbow, again. The full can exercise. Submaximal isometric internal-external rotation. And they can do open chain proprioceptive exercises, making circles, doing the alphabet, so they're lying on their back, making circles, writing the alphabet, and we continue to make sure their range of motion is progressing. Okay. Here we want them into, they can start strengthening. It's usually around 8 to 12 weeks. We want to make sure they have adequate range of motion, they're not substituting, and that their scapulothoracic musculature is firing. They can be progressed to isotonic exercise, light closed chain stability. Okay. Internal external TheraBand with a towel between the trunk and arm to encourage proper technique and to minimize substitution. We talked about that bear hug exercise for the serratus. Rowing for the traps and rhomboids, prone lower trap exercise, which we talked about. They can start strengthening the biceps and triceps because the bicep plays a role in forward flexion and helps to stabilize the joint. Okay, and an initial closed chain. They can do rhythmic stabilization in quadruped using weight shifting. The therapist can give perturbations, and all this is going to improve static control basically through just the compression of the weight down through the glenohumeral joint. And that's going to increase muscle activation and improve stability. Okay, and that next phase, that advanced strengthening phase, pretty much we want to make sure the patient has pain-free ADL. There's no pain or substitution with all the exercises they've been doing. Active range of motion is normal. There's no scapular dyskinesia at all different angles. And these patients too can progress. The remodeling phase is close to completion. The repaired rotator cuff tissue is relatively mature and it can withstand greater forces and stresses. So they can start performing external rotation both at 45 degrees and 90. Serratus exercises, rhythmic stabilization at 90-90, manual PNF, ball throws, using the rebounder or throwing against the wall, and then other upper extremity plyometrics, and then eventually phase 5, return to sport. So I just ran through that. I just wanted to give you an idea of progression of exercises, of what different exercises you use at what point. That was definitely for, that was a post-surgical patient, so most likely there was a protocol where the patient wasn't allowed to do certain things at certain times, so that's something to be aware of. But I just wanted to give you an idea of progression, and that's just one example of progression. So I know I threw a lot at you. There are a lot of different exercises. What I think would be good would be for you guys to go through these exercises, do them yourselves, know what they feel like, so you know what the patient is feeling. Try them using different weights, okay? So you kind of get an idea of what you can do, and that's going to help you, somewhat gauge what your patient might be able to do. I know everybody's different, but it'll give you an idea of what weights to use and things like that. So I really suggest you go into the gym or get some weights or things like that and practice all these different exercises. The more you do it, the easier it's going to be to explain them to the patient, because you're going to know what they feel like. You're going to know how to do them properly. And so that's going to allow you to better educate your patient. Please send me your muddiest and clearest points. And thank you very much.